recently did a poll of my colleagues and asked them if there was only one monitor that they could use in the operating room, what would it be if all other monitors failed? And 2/3 of them said Untitled CO2. This is the most useful monitor for most of my colleagues. And the reason why is that this monitor looks at cellular metabolism, it looks at blood flow through the body, that's cardiac output and venous return, it looks at gas exchange across the pulmonary capillary interface, and of course it looks also at alveolar ventilation. So it's a tremendously useful monitor, and that's what this tutorial is about, end-tidal CO2. End-tidal carbon dioxide. Previously, we looked at ventilation and I discussed the basic physiology of alveolar ventilation, and then we looked at the causes of hypercarbic respiratory failure. Subsequently, we moved on to talk about dead space to tidal volume ratios and how PEEP and auto-PEEP are causes of increased physiologic dead space. In this tutorial, we will discuss some basics about gases and in particular carbon dioxide. We'll talk about capnometry versus capnography, and then we'll talk about identifying abnormal capnographs. Let's start with a clinical scenario. You're in the operating room and the patient you have on the operating table is Brenda, and she's 55 and she is undergoing a total abdominal hysterectomy under general anesthesia. 1 hour into the case, her heart rate is 60, her blood pressure is 105/65, she's on volume control ventilation receiving 375 mils 12 times per minute on a PEEP of 5 and an inspired oxygen tension of 30%. Her saturation is 99, her end-tidal CO2 is 40 or 5.1 kPa, but 5 minutes later the CO2 drops to 20 millimeters of mercury or 2.6 kilopascals. Well, what's going on here? Well, to explain this, we need to roll back and look at the monitors that we have in place, and in particular this monitor that's known as end-tidal CO2. It's important to understand that when you hear the term end-tidal CO2, that means the partial pressure of carbon dioxide in inspired gas at the end of tidal exhalation. Not the beginning, not the middle, but the end. This is the maximum point of CO2 exhalation, and it immediately vanishes as inspiration starts. The correct term is really the partial pressure of end-tidal CO2, the PETCO2, but we usually shorten it to etCO2. In physiology, carbon dioxide is always a gas. You may be familiar with the grey cylinders of CO2 that you may use, for example, if you have a soda stream. But at all temperatures on the face of the earth, end-tidal CO2 is a gas, and it is only liquidized by applying high pressure. The critical temperature is 31 degrees Celsius. So physiologically, the CO2 is always a gas. And as it is always a gas, it obeys Henry's law. Well, what is Henry's law? Well, gases dissolve in liquids. This has always been known. And the amount of gas that dissolves was described over 200 years ago by William Henry. And he defined the amount of gas and the tendency of gas to dissolve in liquid as being determined by both pressure and temperature. In the body, that means that the total quantity of CO2 dissolved in the blood is proportional to the partial pressure of CO2 gas. That's the pCO2. The higher the partial pressure of CO2, the more CO2 that dissolves. And what that means is that if the tissues are making carbon dioxide, the more carbon dioxide gas that's made, that CO2 dissolves it travels outside of the cell into the interstitial space and into the blood, and it dissolves in the blood. And the higher the partial pressure of that gas that's produced, the more CO2 that's in the blood. And that's why you can measure carbon dioxide using a blood gas machine. So higher the pressure, more CO2 dissolves. And the more metabolic activity, the greater the pCO2 in the blood. So CO2 is a great measure of metabolic activity. Also, if the body fails to clear CO2 effectively, the pCO2 will continue to increase. So that's pressure. The other fact that's important to remember is that there is an impact of temperature on the solubility of CO2. And the lower the temperature, the more carbon dioxide dissolves in blood. Well, you know this, of course, that the ice caps are able to hold lots and lots of CO2. And it's the same thing with your blood. As your blood cools, it holds more CO2. And in fact, this is true of all liquids. The cooler the liquid, the more gas dissolves in it. And you'll be familiar with this, because if you've ever boiled a saucepan of water, you will notice as soon as you start to heat it up, you'll see small little bubbles of air coming out of the liquid, because that gas will no longer fit in between the water molecules. So that air comes out, and as you heat it further and further, more and more air bubbles out of the liquid and into the air, because the hot water can hold less air in it than cold water. The second law that you must be aware of if you're dealing with gases is Dalton's law of partial pressure. Remember that carbon dioxide has a molecular mass, and it can be quantified in terms of moles, millimoles, and grams. Being a gas, we know that 1 mole of carbon dioxide occupies 22.4 litres. And we also know that when placed in a container with a mixture of gases, the pressure applied by each gas on the container wall is directly proportional to the relative quantity of each gas. And this is known as Dalton's law. So let's just make up a container here, and we put some gases in. And imagine that this container has a pressure in it of 1 atmosphere, or 760 millimeters of mercury, or 101 kilopascals. And we're going to put in 70% of that gas that's in there will be nitrogen. So let's put in nitrogen in there. And because 70% of 760 is 532 millimeters of mercury, or 70 kilopascals, that is the impact of nitrogen inside this container. Now we're going to put in 19% oxygen, and that works out at 144 millimeters of mercury, or 19 kilopascals. We can put in some water vapor in here, 6%, and that works out at 46 millimeters of mercury. How did I figure that out? This is 760 divided by 6%, 46 millimeters of mercury, or 6 kilopascals. You'll see the 6 looks very, very like the 6% here. And finally, carbon dioxide, 5%, 38 millimeters of mercury, or 5 kilopascals. This looks a bit like airway gas. It's not exactly how you measure airway gas, but it's nice to see that neat relationship between the percentage of gas and the pressure in kilopascals, one of the advantages of using kilopascals. Now let's move on to carbon dioxide. Carbon dioxide is produced in cell mitochondria. It's then diffuses across the wall of the cell and into the interstitium and then into the bloodstream, and of course it equalizes across the entire extracellular fluid. So it's transported in systemic veins, some of it within red cells and some of it just in the blood, and then it moves along into the pulmonary artery, dissolved or bound to hemoglobin, and once it gets into the pulmonary artery, it's then exposed through the pulmonary capillaries to the air-gas interface. Remember that the liquid-gas interface. Remember, the blood is liquid and the alveoli are air, and the gas diffuses from the liquid across the pressure gradient into the lower pressure area of the alveoli. So if the pressure of CO2 is higher in the pulmonary capillaries than in the alveoli, gas diffuses across, and that's what normally happens. So CO2 diffuses across this liquid air interface, and the tension within the alveoli is the alveolar CO2 tension, the P large A CO2. Then of course the CO2 passes through the dead space airways and all the way out through the mouth and into the atmosphere, where it's exhaled, and there is a partial pressure gradient all along that way, but of course it does need to be projected outwards by tidal exhalation. If you're looking at the numbers here, roughly, and these are just estimates, the partial pressure of CO2 intracellularly is about 46 millimeters of mercury, or 6 kilopascals. It's about 44 millimeters of mercury in the pulmonary artery and pulmonary capillaries. That's 6 kilopascals. In the alveoli, it equalizes with the arterial blood, so it's about 40 millimeters of mercury, or 5.1 kilopascals. End tidally, that's at end exhalation, it's about 35 millimeters of mercury or 6 kilopascals, and in the arterial blood it's again 40 millimeters of mercury or 5 kilopascals. So there is a bit of a gradient of about 3 to 5 millimeters of mercury, 1 and a bit kilopascals difference between the end-tidal CO2 and the arterial CO2. And for most patients, most of the time, that difference is the same. So if you do a blood gas and you have a patient on a ventilator and you're measuring end-tidal CO2 and nothing much changes, you can pretty much guesstimate what the arterial CO2 tension will be for that patient. It is important to look at CO production and clearance as being a bit like a conveyor belt. Sort of what you'll see at a sushi restaurant. Carbon dioxide is continuously being produced by tissues as part of metabolism at a baseline rate of 200 mils per minute, and that can increase exponentially with exercise. A specific proportion of manufactured CO2 must be removed from the blood each minute to maintain a partial pressure of arterial CO2 at approximately 40 millimeters of mercury or 5 kilopascals. What happens if that quantity of CO2 is not cleared? Remember that CO2 is produced by cellular metabolism. It diffuses across the cell wall, the cell membrane, and that's freely permeable to carbon dioxide. Some of the carbon dioxide dissolves in the blood, some of it enters erythrocytes. When it does so, it's hydrated with water in the presence of carbonic anhydrase to carbonic acid. That ionizes immediately to release bicarbonate. The hydrogen ion is bound by hemoglobin, which is an excellent buffer, and indeed some of the CO2 binds directly to hemoglobin. Quite a lot of it, in fact, binds directly to hemoglobin, known as carbaminohemoglobin. The bicarbonate then diffuses out of the cell and it's swapped for chloride in a process that's known as the Hamburger shift. On your blood gas, you will read the total CO2 content, and that comprises the partial pressure of CO2, which is essentially the diffusible dissolved carbon dioxide measured at 37 degrees Celsius. There's also carbaminohemoglobin and bicarbonate, and if you were to graph this to look at the total quantity of CO2 in the blood at any given time, so just at this snapshot in time, not how much is made per day, but just at this moment in time, a very, very small proportion of that is actually dissolved gas. Even though that's what we measure, it's only a tiny proportion of it. About a third of it is actually bound to hemoglobin, and 2/3 exists as bicarbonate. It is imperative that you understand that plasma bicarbonate rises in direct proportion to CO2. It is not some form of renally associated metabolic compensation. That, incidentally, is achieved by wasting chloride if the CO2 level builds up. Hypochloremia is how our body deals with long-term hypercarbia. Bicarbonate is CO2, and if the total amount of CO2 in the body rises because of poor clearance or excess production, then the bicarbonate naturally rises. Now that we know about the total CO2, we must understand the partial pressure of CO2 and how it can change when there are changes in ventilation. In this model from Nunn's physiology, we can observe a patient who has a partial pressure of CO2 of 44 millimeters of mercury or 5.3 kilopascals, who is receiving about 3.3 liters of minute ventilation. Now, watch what happens when the minute ventilation is increased to 14 liters. Look how quickly the CO2, the PCO2, drops down to below 20 millimeters of mercury or 2.5 kilopascals. It really is skimmed off very, very, very rapidly. So if you increase alveolar ventilation, the reduction in the plasma and our blood CO2 level, and indeed extracellular CO2 level, is very, very dramatic and very, very quick. Conversely, if you have the same patient who starts off with a low PCO2, here we have a CO2 at the lowest level, and the patient's on a starting minute ventilation of 14 litres per minute, and what we're going to do here is we're going to turn the minute ventilation down to 3.3 litres per minute. Now look what happens, and you can see here that the buildup of CO2 is much slower than the washout of CO2, and the reason for this is because CO2 is being produced at 200 mils per minute, and the plasma buildup is proportionate to the metabolic activity. And it means that if you make a ventilator change and you slightly underventilate the patient, checking a blood gas, for example, at 10 minutes may be quite misleading, because that CO2 is going to continue to build up gently over many hours. So you need to be a little bit careful. Now, of course, if the patient has been rendered apneic and there is no alveolar ventilation, well, it takes about 8 minutes for the CO2 to double. Let's just look at a little bit of basic science here. We produce at rest 200 mils of carbon dioxide per minute. How many grams of CO2 is this? If you listen to the media, you'll hear people talking about grams of CO2 all the time. So how many grams of CO2 do we make per minute in our body? So let's work the problem. Carbon dioxide, one atom of carbon has an atomic mass of 12, plus 2 atoms of oxygen with an atomic mass of 16. That gives you a molecular mass of 44. So 1 gram, or 1 mole I should say, of carbon dioxide is 44 grams. So 1 gram molecular weight is a mole. So there's 44 grams in a mole. And that works out using Avogadro's hypothesis to 22.4 litres of gas. So 1 mole of CO2 is 440 milligrams, or 22.4 mils. 1 gram of CO2 is 22.4 divided by 44, or 500 mils. So 1 gram of CO2 is 500 mils of gas. 200 mils, that's what we produce per minute, is 2/5 of a gram. So we produce 0.4 grams of carbon dioxide per minute, and that works out at 24 grams per hour, or 12,000 mils, or approximately half a mole of carbon dioxide per hour, or 576 grams of carbon dioxide per day, about 14 moles per day. Now that might seem like a lot, and on the surface of it is, but hang on a second, my car produces 320 grams of CO2 per kilometer. Yes, it does. A big car with a big petrol engine. That means if you drive this kind of car, you're making 160 litres of CO2 for every kilometer. If you commute 20 kilometers, then your car is making 6,400 litres of carbon dioxide per day, and that is just going to and from work. It is staggering. So how do we actually measure carbon dioxide and gas in the body? Well, there are 2 ways. We can measure the partial pressure of CO2 in both arterial and venous blood using a blood gas machine, keeping in mind that the machine adjusts the temperature of blood to 37 degrees Celsius, because we need to be able to compare blood gases across different temperatures. Sometimes patients develop fever, sometimes they get very cold, and so you need to be able to compare like with like, because the solubility varies with temperature. We can also sample the CO2 content of inspired and expired gas, and when we are talking about the latter, it's called end-tidal, as in the end of the tidal volume, carbon dioxide. Now there are 2 ways of measuring CO2 and expired gas. The first one is using a capnometer. And capnometry refers to the measurement of carbon dioxide in end-tidal gas, and it is numerically quantified as a partial pressure. Capnography refers to the graphical display of carbon dioxide in the breathing system throughout the respiratory cycle. The capnographs will always give you a capnometry measurement. There'll always be a number, but you also get a waveform. So while capnometry is great and it provides you with quantitative data and confirms intubation and ventilation, overall capnography is more useful. So let's now talk specifically about capnometry. One of the worst things imaginable is if you were called to a cardiac arrest, that you intubate a patient, you see bilateral chest movement, the person who listens to the chest says there's bilateral air entry, there is steam in the endotracheal tube, and you think you've successfully intubated the patient, but the patient becomes progressively more hypoxemic and dies. And then it turns out that the patient was intubated into the esophagus. To resolve this problem, capnometry was developed specifically for situations outside of the operating theatre to ensure that patients have been adequately intubated. And so you may come across this particular device. It's a terrific little device that's purely there to ensure correct placement of the endotracheal tube. It's a very basic capnometer that looks like a heat and moisture exchanger. Now in this picture we have just intubated the patient, and we have attached the end of the end-tidal CO2 indicator to the endotracheal tube, and on the other side is the anesthesia breathing system, or an ambibag. And then what you do, and you can see here that the little window, by the way, is yellow on this. And what you do is you bag the patient, and as the bag refills, carbon dioxide should pour out of the patient into the device, and then it changes to purple, indicating that carbon dioxide is coming out of the patient. Carbon dioxide can only come out of the lungs. There's no carbon dioxide in the stomach. And if CO2 comes out, the color changes, then you can be pretty sure that the tube is at least in contact with the airway. It may not be in the correct place in the airway, but at least it's in the airway some way or other. If you do bag the patient, and of course the bag refills, but the color does not change, the tube is not in the airway. It's likely in the esophagus. It doesn't matter whether the person who intubated the patient was certain that they saw the tube passing through the vocal cords. If it doesn't change to purple, the tube is not correctly placed, and then bag and mask ventilation should take place. Perhaps the placement of a laryngeal mask or another attempt at intubation should be made. Sometimes people say to me, well, is the saturation probe not good enough? And I would say, well, no. No, it's not good enough. In most situations where a patient is intubated, high concentrations of oxygen have been administered. If you fill the lungs with oxygen, remember the lungs are normally nearly 80% filled with nitrogen, this prolongs the non-hypoxic apnea duration for several minutes. And even if you get all that stuff of bilateral breath sounds and all that, chest rising, it can be so misleading, because you can intubate the patient, the saturations look great, but the patient is getting progressively more hypoxemic. And what will happen is, down the line, 5 to 7 meters later, the patient will suddenly become really hypoxemic and go into a pulsus electrical cardiac arrest, an asystolic arrest. So the only thing that is reliable is Untitled CO2 to confirm tube placement. Unless you can stick a bronchoscope straight down through that endotracheal tube to see the carina, then, and you're not going to do that very often, except perhaps if you're performing a tracheostomy, you must check Untitled CO2. It is the only reliable measurement that we look at in anesthesiology and critical care. Now, there are more advanced devices that can be used at the bedside and for transport, and this is a great little handy version of an old technology. This technology is known as mainline CO2 monitoring, and the CO2 monitor is placed in the breathing system, and it works on batteries, and there is a numerical display, and sometimes actually even a graphical display of CO2, and it measures CO2 as it passes out of the circuit directly and generates a number which should correspond with the Untitled CO2. So once the breath has been delivered and the bag refills with expiratory gas, the capnometer displays a number, and that number should correspond with the partial pressure of arterial CO2. For example, 40 millimeters of mercury, the capnometer number should be just a little bit lower. And what's really great about this is that if you know that the partial pressure CO2 is 40 and the capnometer is saying 38, 39, you can be really sure that that tube has been placed in the trachea and that it's nicely sealed. If the number that comes back is 25, it means that you're in the airway. For example, you might be just stuck in the larynx or maybe in the upper pharynx and there's a big leak. So it's tremendous because it gives you really good real-time feedback and it is instantaneous. Every anesthesiologist will tell you that the standard side stream gas analyzer, and we'll talk about this a little bit later on, incurs a delay, and time just seems to stand still waiting for the waveform display. This will be instantaneous. It just gives you a number straight away. So these are terrific, and these were used, earlier versions of these were used, they were connected to a big monitor back in the day, and these are available and they were very popular during the COVID pandemic. But there is so much more to just measuring end-tidal CO2 than confirming tube placement. Okay, so you can confirm the position of the airway device, but it also gives you information about cellular metabolic activity. Without cellular metabolic activity, there's no carbon dioxide. But for the carbon dioxide to travel from the cells to the lungs, there must be blood flow or cardiac output. So it gives you information about blood flow from the tissues into the pulmonary circulation and all the way around. It also gives you information about gas exchange across the pulmonary capillary alveolar interface, the liquid to gas interface, because without that interface being present, then no end-tidal CO2. It gives you information about alveolar ventilation, that is moving gas in and out of the lungs. And finally, it's very, very helpful for diagnosing cardiopulmonary disease. Once you have intubated a patient and confirmed that the patient's tube is in the correct position and generated a capnometer number, you need to continue to follow this number throughout to maintain the end-tidal CO2 at the level that you think is appropriate for the patient. For most people, that's an end-tidal CO2 of about 35 millimeters of mercury, or just around 4.9 to 5 kilopascals. Of course, if the patient normally has a high partial pressure of CO2 in their blood, someone, for example, with COPD, you will target a higher level. Sometimes once you've started mechanical ventilation, that end-tidal CO2 starts to rise, and you need to have a way of thinking about working the problem if this happens. So let's start in the operating room. You have a patient on the table called Ralph, and Ralph is 54 and he's undergoing a robotic assisted prostatectomy. Now this requires a general anesthetic, and we are now 45 minutes into surgery. The patient is paralyzed with neuromuscular blocking agents. He's on a remifentanil infusion, which will reduce all his metabolic and adrenergic activity, and he's on an inspired oxygen tension of 30% or 0.3. His tidal volume is 475 mils, respiratory rate is 12, and his end-tidal CO2 after intubation was 38 millimeters of mercury, or in and around 5 kilopascals. Over the next 30 minutes, the end-tidal CO2 has been progressively rising, and it's now 50 millimeters of mercury, or 6.6 kilopascals. Well, what's going on here? Let's work the problem. I always start at the cells and work my way through the circulation to the lungs, but there's various different ways of doing it. So metabolically, the first thing you have to think about here is that you just hypoventilated the patient from the start. Remember the picture from Nunn's respiratory physiology, whereby the CO2 takes quite a long time to build up in the blood. So you get this progressive increase in end-tidal CO2 purely because that minute ventilation that you gave Ralph at the beginning was just inadequate for him. But the second thing is you need to look at the operation, and a robotic assisted prostatectomy is a laparoscopic procedure, and the abdomen is insufflated, the peritoneum is insufflated with carbon dioxide in order to allow the laparoscopic surgeon to see what they're doing, and of course some of that CO2 will be absorbed. So you need to think about that, and if that's the case, and of course if the hypoventilation is the case, you need to increase the minute ventilation. Occasionally there's a dramatic increase in metabolic activity, which may, for example, occur due to a thyrotoxic crisis or malignant hypothermia, but these are very, very rare to encounter in clinical practice. But something you need to think about: in the case of malignant hypothermia, the patient's temperature will exceed 40 degrees Celsius. The second thing to think about is Pulmonary, and there are a couple of reasons why the end tidal will go up in someone who's on a ventilator. The first thing is if they're on spontaneous ventilation, it may be that they're just hypoventilating and over time the CO2 builds up. But the second thing is you may actually make a vent change that will improve overall ventilation perfusion matching. For example, reducing dead space by reducing the PEEP, or reducing the mean airway pressure, which is the same effect by giving the patient a longer I to E ratio, and this is a very good example of good clinical practice. And of course, the third reason why the end tidal might rise during anesthesia is just improved overall global hemodynamics, improved cardiac output, improved flow from volume resuscitation, particularly with blood, or the administration of inotropes or vasopressors. Remembering that induction of anesthesia is associated with a dramatic increase in the unstressed blood volume, and because of that, the flow to the lungs will reduce, and the end tidal may well be lower than it should be. And once you give the patient some vasopressors, like for example phenylephrine, the blood flow in the stress circulation improves, and this improves overall global hemodynamics, and as a consequence of this, the end tidal CO2 will rise. Also, there are examples in clinical surgery where the circulation may be interrupted. For example, where an aortic cross clamp has been placed, or a tourniquet has been placed, or the patient's been on cardiopulmonary resuscitation. And when these situations are reversed, the end tidal CO2 goes up because there's a lot of carbon dioxide trapped in the extremities that have been shut off from the circulation. In the ICU, you kind of think the same way. There are a few different things that you may not have thought about. For example, once you start intravenous nutrition, or TPN, which is often started at a fairly high level, you're now delivering a lot more carbohydrate to the patient that increases metabolic activity and will generate more carbon dioxide. Similarly, if there's any cause of increased muscular activity like shivering or agitation or seizures or reversal of neuromuscular blockade or even rewarming after hypothermia, then the end tidal CO2 will go up, particularly when the patient is rewarming because, of course, less CO2 dissolves in warm blood. On the pulmonary side of things, of course, with hypoventilation, when you put someone on a spontaneous breathing trial, you should keep a close eye on the end tidal CO2 because it just gradually increases over time as the patient hypoventilates, and it may be a reason to end a spontaneous breathing trial when you see a dramatic rise in the end tidal over half an hour, an hour and a half. Not immediately, of course. And then, of course, as I've mentioned before, overall improvements in perfusion associated with better cardiac output from volume resuscitation, inotropes, and vasopressors is associated with an increase in the end tidal CO2. Well, what about a fall in the end tidal CO2? This may occur from the offset where the carbon dioxide tension in expiratory gas is just low, and there's medley reasons for this, or else the patient may have had a normal end tidal CO2 and then it's progressively fallen or suddenly fallen. And that was the case of Brenda. This was the lady in her 50s who was having a general anesthetic for a total abdominal hysterectomy, and her end tidal CO2 all along was 40 millimeters of mercury, or 5.1 kilopascals. In the middle of the operation, the end tidal dropped to 20 millimeters of mercury, or 2.6 kilopascals. Well, let's see if we can work out what happened to this woman. At this stage, we need to really begin to look at ventilation perfusion relationships, and this is a cartoon of normal ventilation perfusion relationships. The balloons here represent various alveoli. The blue represents the pulmonary artery. Remember, this deoxygenated blood, and the red is the pulmonary vein, which also essentially represents the systemic arterial circulation. And you can see that the partial pressure of oxygen in pulmonary arterial blood is about 60 millimeters of mercury, or 8 kilopascals. The pulmonary arterial PCO2 is 44 millimeters of mercury, or 5.1 kilopascals. The alveolar oxygen tension is 100 millimeters of mercury, or 13 kilopascals, and the alveolar PCO2 tension is 40 millimeters of mercury, or 5 kilopascals. Each of these lung units is very well perfused and very well ventilated, just like it presumably is for you right now. Consequently, the end expiratory PCO2 is 35 millimeters of mercury, or 4.6 kilopascals. So there's a slight gradient, as you would expect, from the alveolus to the air. If blood clots travel from the legs or pelvis into the right side of the heart, they are propelled into the pulmonary arterial circulation. End arterioles will become plugged up and blood flow will stop through these units. The alveoli that they perfuse will become dead space, and the result is that the clearance of CO2 will be reduced with a corresponding fall in the end-tidal CO2, and that is what's happening to Brenda. She is suffering from a pulmonary embolism. So that's why the end-tidal CO2 has fallen here. And it is critical that if you see a sudden fall in end-tidal CO2 like this during an operation, you take the situation seriously. Now, what happens next is important to understand. Blood can no longer flow through plugged off parts of the lung, and that blood redistributes itself to lower resistance channels, flooding some alveolar units with blood. The flow is so high that there is insufficient time and surface area for gas equalization, with the result that some lung units develop low ventilation perfusion characters, and the result is hypoxemia from flooding. Often the first blood gas abnormality that is spotted in pulmonary embolism is hypoxemia, but this is the second abnormality. So this is an example of VQ mismatch due to overflow of blood to normally ventilated units in the lungs. In this situation, the end-tidal CO2 starts to increase again, but doesn't come back to normal because the patient will tend to hyperventilate if they're breathing spontaneously, and the dead space continues to be a bit of a problem. Now, there are other causes of low end-tidal CO2. Metabolically, as I've mentioned before, the patient may be hyperventilating, secondary to metabolic acidosis, or they may have hypocarbia secondary to hypothermia. In terms of the pulmonary circulation, there may be it may happen early after initiation of spontaneous ventilation or increased dead space, and that increased dead space may be caused by excessive PEEP, auto PEEP, or hypotension with a high mean airway pressure. And also, of course, there's perfusion problems where the cardiac output is low, and this is often a sign of vasodilatation, a low cardiac output, and it's seen with hypovolemia, cardiogenic shock, or an obstructed circulation. Let's move on to capnography. Capnography is a carbon dioxide, as in capnograph, measurement, and it involves sampling inspiratory and expiratory gases via a specifically designed tube attached to the breathing system, and it's known as side stream gas analysis. The gas monitor measures the carbon dioxide content of the sampled gas continuously and displays a waveform on the screen. It also displays an end-tidal CO2 number. So you have two things here. You have a waveform and you have a number. And this is the setup. Here's your ventilator tubing. You have a catheter mount, an endotracheal tube or a laryngeal mask airway, or even a face mask. A heat and moisture exchanger, and on the far side, on the ventilator tubing side, not on the patient side, there is a little side port that attaches to this side stream gas sample tubing. This connects into the monitor. Sometimes there's a water trap, and that monitor then uses a variety of different technologies to measure the gas content of the sampled expiratory gas or inspiratory gas. And finally, there's a digital and waveform display. Now, this is an example of what we use in our operating theatres currently. You can see here that there's a heat and moisture exchanger with a little side port on it and a gas sample tubing, and that connects into the gas analyzer. In the ICU, there is no heat and moisture exchanger. It's purely a plastic tube that connects in between the catheter mount and the ventilator tubing with the side port on it. And this eventually connects straight into the monitor. When the patient exhales, gas flows out of the endotracheal tube or laryngeal mask into the heat and moisture exchanger, where part of the expiratory flow is sampled by clear plastic tubing and delivered to the monitor via the water trap. The monitor displays a graphic waveform of inspiratory and expiratory CO2 and a number indicating the end-tidal CO2. There is always a delay in displaying the CO2 trace, and this may lag after the airway pressure trace. The heat and moisture exchanger version is used in anesthesia and patient transport. It has no role in intensive care because in the ICU, when you have a patient on the ventilator, there is a humidification system built in. And if you put a heat and moisture exchanger in the middle of that, it just becomes saturated and it's rendered inoperable and potentially dangerous. So in the ICU, you have different sampling connections, as I have already shown. Now that is how gas is sampled, and I'll show you a few traces in a second, but there is something that you should be aware of with this, and there is a slight flaw in the system because the CO2 monitor is connected proximal to the ventilator tubing, and if that tubing disconnects, as it may do so under anesthesia, and if the patient is breathing spontaneously, you may see a normally end-tidal CO2 trace on the monitor while the patient is breathing room air that does not contain volatile anesthetic and indeed enriched oxygen. This risks awareness or worse, the patient waking up in the middle of the operation and moving around. This is one of the reasons why it's imperative to measure inspired and expired oxygen and set your alarms carefully. Let's look at some capnograph traces. Now, this is the normal capnograph. Just take note of the different axes here. On the left-hand side, you'll see the end-tidal CO2 in millimeters of mercury. You can divide that by 7.6 for kilopascals. And on the horizontal axis, we have time. Now, during inspiration, there's no CO2 because there's essentially no carbon dioxide that is measurable in inspired air. Most of the time anyway. And then as the patient starts to exhale, the first gas that leaves the airway is the gas that's in the upper airway, which has very little CO2 in it. And then as gas moves further along, remember it's being propelled from the alveoli all the way out, you start seeing the amount of carbon dioxide gradually increasing up until most of the gas that's coming out is alveolar gas. So you see this upward curve that plateaus, and then it hits a kind of a sharp edge and then falls down like a cliff. That initial upward deflection on the waveform represents a lot of dead space gas, not all dead space gas, some alveolar gas, but it's mixed. The plateau is where most of the gas that's coming out is alveolar gas, so that's the important bit. And the bit at the end, right there at the corner, is the end-tidal CO2. That's the point of maximal CO2 exhalation just before the patient cycles themselves into inspiration. So this is what a normal capnograph looks like. And it should be shaped very much like a hat, a nice square-shaped picture. This is the point of the end-tidal CO2. Let's look at a couple of scenarios now. Tanya is brought into the emergency department complaining of chest pain, and she has rapid shallow breathing and she is intubated. And you attach the end-tidal CO2 monitor on her, and this is her first capnograph. And as you can see, it's completely normal. However, 30 minutes later, you notice that the trace changes. And this is what the trace looks like. And you can see here that nice square-shaped trace is suddenly replaced by a kind of a squiggle. So what's going on here? Well, what has happened here is the end-tidal CO2 has essentially vanished. It's fallen to near zero. And what's happened here is you have lost your airway. Something has happened. Either there is a disconnection in the system. So, for example, if a heat and moisture exchanger that has fallen off, or more likely the patient has accidentally extubated, and the tube has come out. In this situation, the tube came out and you re-intubate. 30 minutes later, you see the following trace. So what's going on here? In this situation, you still have a CO2 trace. It hasn't gone to zero. There's a lot of squiggling going on. So carbon dioxide is definitely coming out of the patient. But it seems that not all of that carbon dioxide is being captured. And if you think about this, that means that the tube is adjacent to the airway, but not necessarily sealing the airway off. And what's happened here is that there's either a partial extubation, in other words, for example, the tube may have migrated up into the larynx, or the cuff of the tube has been ruptured for some reason, or else there's a leak within the ventilatory circuit on the exhalation side. Perhaps there's a problem with the catheter mount. Following this, you change the tube and you check the cuff and all looks okay. And 30 minutes later, you see this trace. What's going on here? Well, you can see here in this trace you have a normal end-tidal CO2 trace, and each subsequent trace is the same shape, but the volume is lower, right? So the end-tidal CO2 is dropping breath on breath on breath. This is an exponential decrease. You can see that line. It's an exponential decrease. And this is a characteristic trace of pulmonary hypoperfusion. This is not good. This is evidence of an imminent cardiac arrest due to a pulmonary embolism or right heart failure. And you need to get on top of this immediately. Let's look at a few more traces that we may see more commonly in anesthesiology or in intensive care. And here we have our plot, and we're going to see yellow lines of end-tidal CO2 trace. So here is the end-tidal CO2 trace on this particular patient. Well, what's going on here? What you're seeing in this particular picture is a progressive increase in the end-tidal CO2. You notice it starts at about 20 millimeters of mercury and then starts working its way up until it's 50. And this is what you characteristically see in a hypoventilating patient. I'm going to try and explain this, and I think all anesthesiologists and nurse anesthetists should be aware of this phenomenon. Let's start at the very beginning. The patient's alveolar CO2 is 40 millimeters of mercury, or 5.1 kilopascals, essentially the same as what's in the pulmonary venous blood or the systemic arterial blood. And the patient starts to breathe, but the breaths are shallow. So essentially what is being moved out of the airways is dead space. And so what you see initially is the partial pressure of dead space CO2 coming up on the end-tidal CO2 trace. And in this situation, it's 20 millimeters of mercury, or 2.6 kilopascals. Patient continues to breathe with these shallow breaths, and then after maybe 30 breaths or so, the partial pressure of CO2 in the alveoli has now gone up to 50 millimeters of mercury, or 6.6 kilopascals, because you're not clearing any CO2. The CO2 is essentially running around through the systemic circulation back onto the venous circulation. It's picking up more CO2 as the blood is picking up more CO2 as it's being produced in the tissue. So the partial pressure of pulmonary arterial CO2 has gone up. And so some of this CO2 starts now to make its way up along the gradient, along the dead space, the anatomical dead space, up into the main airways. So the dead space CO2 now is going up to 30 millimeters of mercury, or 4 kilopascals. As time goes on, of course, the more this arterial CO2 builds up, the higher the dead space CO2 and the higher the end-tidal CO2 as a consequence. So by the time we get here to, for example, breath 120, and this is purely an example, we now have a really high partial pressure of CO2 in the alveoli, representing a very, very high partial pressure of CO2 in arterial blood, and a column of CO2 running from the alveoli up into the dead space and up into the airways. And that's why you're seeing this spectacularly high end-tidal CO2 appearing on the screen. And when you see this, you need to do something about it. Either you wait and see how bad it gets, and it will get bad unless it stabilizes, or else you need to put the patient on a ventilator or give them some manual inspiratory support. But you do need to start clearing CO2 from the airways, because that represents arterial CO2, which really seriously acidifies the blood and will cause profound vasodilatation. This is a common waveform that you may see in the ICU and sometimes in the operating room as well. And you can see here there is a really shallow upward curve of the end-tidal CO2 trace. You can see that very, very slow upstroke. And what you're seeing here is slow emptying of the airways. You see slow upstroke, slow emptying of the airways. And this is what you see in patients with increased airway resistance, particularly patients with stubborn asthma or COPD. And this is a really characteristic waveform, and it's something that you must be able to identify, because it helps you diagnose and actually follow the treatment of increased airway resistance or acute severe bronchospasm that may occur at any stage in the management of patients in perioperative medicine and critical care. Now, what I have here is a series of airways going from top to the bottom, and you can see the airway at the top. There's a nice clear passageway between the alveolus and the main airway. So those kind of bronchioles are nice and clean, and so they'll empty really, really quickly when the patient starts to exhale. The second one from the top, you can see there's some constriction of the airway, but it's kind of very it's not that narrow, so those airways will empty fairly quickly as well. And as we go along progressively, the third airway, very tight looking, difficult to get gas out of, and the last one has all kinds of stuff in it that is really, really applying a lot of resistance to exhalation. And so when the gas starts to try to move out of these airways, you'll see that in exhalation there's different rates of elimination of gas from these different airways, and that's why you get this really smooth curve that happens with a slow upstroke. And your job as a clinician is to see if there's anything you can do to improve this. Perhaps it's a chronic problem, or perhaps the patient has acute bronchospasm, and that's the characteristic CO2 trace you should be looking for. Here's another trace. Well, what's going on here? Well, you can see here something very unusual, which you should not see in any patient who has a CO2 monitor on them. And what's going on here is you can actually see carbon dioxide on the inspiratory side of the waveform. Normally this goes down to 0 in inspiration, but it's not. It's climbing stepwise, and this is not good. This is a problem that is sometimes seen in the operating room, and when you see this rising baseline, this means that the patient is rebreathing carbon dioxide. The commonest cause for this in the operating room is that the soda lime that is used to basically remove carbon dioxide from the system has been exhausted, the flow is low, and there isn't CO2 being cleared, so it's coming back on the inspiratory side of the circuit, and the patient is rebreathing carbon dioxide. You sometimes see this with pediatric circuits where the child is breathing so much and generating such a high minute ventilation that the bag that is used as a reservoir essentially doesn't have enough time to fill and clear CO2 out of it, and the patient rebreathes CO2. So what needs to be done here is the flow needs to be turned up and the soda lime needs to be replaced. What about this picture here? Well, what's going on here is you can see the patient is exhaling, but there's a little bit of a divot in the exhalation waveform, and it's happening in every waveform. And what's going on here is this is a patient who's on a ventilator who is trying to breathe themselves. Usually this is when the patient is partially paralyzed and they're coming out of their neuromuscular blockade, and it's known as the curare cleft. There's not a lot to be done with this. You can look at your options to see, for example, if you're only halfway through the operation, the administration of further neuromuscular blockade may be needed. If it's at the end, you can reverse the patient, and if the patient starts to breathe up, they can be transitioned over to, for example, pressure support ventilation. What about this picture? What's going on here? Well, you can see here that the normal flat waveform has a little terminal upstroke on it, and we've seen this before looking at the pressure waveform on other modes of ventilation, but this is on the CO2 trace, and you can see here this terminal upstroke, and that's what you see where a little bit of extra CO2 is pressed out at the very end, so you get this little bump in the end-tidal CO2. And this happens, for example, when there is increased intra-abdominal pressure. It can happen in patients who have abdominal compartment syndrome. It can happen in patients who are morbidly obese, and of course it can happen when there is a pregnant uterus near term. The baby, when the mother tries to breathe, there's a little bit of a squish down to push down a little bit of gas at the end of exhalation. Not a lot to do. This is a normal waveform in these patients, and it's perfectly fine. So let's just wrap this up. When should we be using end-tidal CO2? Well, in all patients undergoing general anesthesia, always. In all situations where an artificial airway is placed in an unconscious or apneic patient. In the majority of patients undergoing procedures that require moderate to deep sedation. And this is very much a modern standard of care in where essentially sedation is given, for example, in patients having endoscopies or sedated for surgery. What about in the ICU? Well, it is now a standard of care to monitor end-tidal CO2 in all mechanically ventilated patients in the ICU. This is based on some evidence that where CO2 wasn't monitored, there were more airway disasters. And it does, of course, give you an idea of patency and positioning of the airway and connected apparatus, and also to estimate the adequacy of ventilation, because if you have a nice correlation between the end-tidal CO2 and the arterial CO2, you don't have to do as many blood draws on the patient to look at how well their ventilation is. You can use it, as I showed in the previous tutorial, to calculate the dead space using the Bohr equation, which is the PaCO2 minus the P end-tidal CO2 divided by the PaCO2. And also for waveform analysis and the diagnosis of circulatory and airway problems, as we have just seen. The major value of end-tidal CO2 is continuous feedback regarding the patency and positioning of the airway, and particularly in spontaneously breathing patients. And just like other ventilator waveforms like flow volume loops and pressure volume curves, visual inspection of capnography traces aid in the diagnosis and management of all kinds of airway related problems. So it's something that you need to be looking at all the time, and it's something that I will emphasize continuously during this course. When you have information display, please look at it and try and see what's going on. Just a final thought. In our diet, we have different foodstuffs, and when we break down carbohydrates, we generate CO2. And we try and clear the CO2, but some of it is converted to bicarbonate. That bicarbonate eventually is turned back into CO2 by a variety of mechanisms. But also be aware, while you're generating carbon dioxide and breaking down carbohydrates are also converted to lactate in vast quantities all day, every day. And that lactate is metabolized in the liver back to carbon dioxide and water. And so it's important to understand that there is a continuum of carbon dioxide, bicarbonate, and lactate going on all the time. And you should think about lactate as being a marker of carbohydrate metabolism, and the accumulation of lactate is a sign of something going on with carbohydrate metabolism. Likewise, we break down proteins into carbon dioxide, and there is a protein waste product that we measure, and that is urea. And that will give you an idea. If the urea is really low, a patient may have protein energy malnutrition. If the urea is really high, perhaps the patient is being overfed. We also feed patients lipids, and lipids are also broken down to carbon dioxide, but they also have a byproduct of metabolism known as ketones, and ketones accumulate in certain situations in the body, and they give us an idea of what's going on with fat metabolism and metabolic function, and so they're worth measuring. And of course, ketones are eventually broken down to carbon dioxide. So when you're looking at bicarbonate, lactate, urea, and ketones, be aware these are all byproducts of metabolism that go hand in hand with carbon dioxide to give us an idea of what's going on in the body. And I'm just giving you this as a teaser for subsequent tutorials that I will cover this material in. But let's review this particular tutorial. We looked at monitoring carbon dioxide as airway gas. We looked at the gas laws applicable to carbon dioxide. We looked at carbon dioxide biology, capnometry and when to use it, capnography and when to use it, and we looked at some practical examples of capnographs. That's the end of this sequence of tutorials on ventilation. Next time I'm going back to modes of ventilation, and we're going to start a 4-part series on pressure support ventilation. We're going to start looking at the concept of assisted spontaneous breathing. Then we're going to move on to triggering of pressure support, and we're going to look at problems with triggering pressure support, the problems of under-triggering and over-triggering. Please join me then, and I guarantee you'll learn something. Well, I hope you found that tutorial useful, and you found these 2 tutorials on ventilation and Untitled CO2 has enhanced your understanding of what we do with carbon dioxide in critical care and anesthesiology. Next time we're going to move on to talk about pressure support ventilation. There are 4 tutorials in all, and I think you'll find them really useful. I guarantee you'll learn something. If you're enjoying these tutorials, don't forget to subscribe on YouTube. Don't forget to leave some likes and some comments. And don't forget, you can also follow these tutorials at ccmtutorials.org. I'll see you soon.